Gestational diabetes mellitus. Gestational diabetes mellitus is an acquired form of diabetes mellitus that presents itself during pregnancy. The common population that gestational diabetes affects is the maternal age older than 25, family history of diabetes, history of glycosuria, overweight, and a diagnosis of GDM with previous pregnancies. This means the risk factors for GDM can be either acquired or genetic. Normally, the islets of Langerhans cells of the pancreas produce insulin. The insulin made acts like a key to transfer glucose from the bloodstream into the cells for energy. During pregnancy, the woman's body metabolizes carbohydrates differently. In early pregnancy, the rise of estrogen, progesterone, and other hormones stimulate increased production of insulin. With the increased production of insulin, a buildup exists during the first half of pregnancy with storage of glycogen in the liver and other tissues. In the second half of pregnancy, secretion of human placental lactogen, prolactin, and the elevated levels of cortisol and glycogen cause an increased resistance to insulin and a decrease in glucose tolerance. The ineffectiveness of insulin results in a destructive state during fasting, because increasing amounts of circulating maternal glucose and amino acids are diverted to the fetus. Maternal fat is metabolized much more readily during fasting periods than in a non-pregnant woman. The change in hormones during pregnancy further disrupts the normal breakdown of carbohydrates and may progress to GDM. 4 common signs of GDM are polyuria, polydipsia, polyphagia, and weight loss. Other expected findings in a woman with GDM include hypoglycemia, nervousness, headache, weakness, hunger, blurred vision, tingling of the mouth or extremities, hyperglycemia, flushed dry skin, fruity breath, abdominal pain, polyuria, polydipsia, polyphagia, and clammy pale skin. A pregnant woman is put at a higher risk of complications when affected by diabetes. Maternal risks include hydramnios, an increase in the volume of amniotic fluid. It is associated to the excessive fetal urination because of fetal hyperglycemia. Premature rupture of membranes may occasionally be a problem with hydramnios. Preeclampsia occurs more often in diabetic pregnancies, especially when vascular damage already exists. Hyperglycemia due to insufficient amounts of insulin can lead to ketoacidosis. Ketoacidosis develops slowly, but if untreated can lead to coma and/or death for mother and fetus. Fetal risks include spontaneous abortion related to poor glycemic control. Congenital anomalies in diabetic patients are the major cause of death among infants of mothers with diabetes. Most anomalies include the heart, central nervous system, and skeletal system. Infants of mothers who are on insulin are often large for gestational age. If born vaginally, the infant is at increased risk for shoulder dystocia and traumatic birth injuries. Infants may demonstrate intrauterine growth restriction. All women, regardless of risk factors, should be screened for diabetes during the first prenatal visit. A woman with high risk factors should be screened for diabetes as soon as possible. Various screening techniques may be used to identify GDM through 1-hour glucose tolerance, fasting glucose tolerance, routine urinalysis for glycosuria in the presence of ketones. Women between gestational age of 24 to 28 weeks are advised to take the oral glucose tolerance test. For the procedure, the woman will drink a 50-gram glucose substance, and then the blood glucose is tested in 1 hour. If the blood sugar is greater than 120, the mother will need to come in a second time after fasting overnight and repeat the test at the first and third hour following the glucose intake. Another potential identifier would be an A1C equal to or greater than 6.5%. The mother must test positive on 2 separate tests to be diagnosed with GDM. A possible nursing diagnosis for a mother with gestational diabetes would be at risk for unstable blood glucose level related to pregnancy, as manifested by abnormal blood glucose levels during gestation. The patient will want to effectively manage hyperglycemic and/or hypoglycemic episodes. Blood glucose levels should be checked before every meal and at bedtime, and monitored during times of stress. Knowing the blood glucose level allows the client to be properly treated by either administering insulin or glucose. The mother should be educated on the signs and symptoms of hyperglycemia and hypoglycemia. The client should always keep items like fruit juice or regular soda to spike blood sugar on their person in case of hypoglycemic events. Following the glucose intake, a carbohydrate should be paired to maintain an adequate glucose level. Initial treatment for GDM includes moderate physical activity, dietary changes, support from diabetes educators and nutritionists, and glucose monitoring. If the patient's glucose is not controlled after these initial interventions, the patient may be prescribed medication and have increased surveillance in prenatal care or changes in delivery management. Education for the mother with gestational diabetes would start with the treatment of the disease by self-administering insulin and taking blood sugars with every meal and at bedtime. The mom will want to increase her calorie intake with an extra 300 calories but limit the amount of carbohydrates taken in. For fetal well-being, mom should do a daily fetal kit count. Following delivery of the newborn, the mother will come back for a glucose tolerance test in 2 weeks and then every 3 years to screen for the development of type 2 diabetes. If the mother has no previous significant vascular damage, the prognosis is generally positive. The mother's blood glucose levels should return to normal postpartum, but the mother has a higher risk of developing type 2 diabetes mellitus 5 to 15 years after delivery. An NCLEX question for GDM is: a nurse implements a teaching plan for a pregnant client who is newly diagnosed for gestational diabetes. Which statement, if made by the client, indicates a need for further teaching? I need to stay on a diabetic diet. I will perform glucose monitoring at home. I need to avoid exercise because of the negative effects of insulin production. I need to be aware of any infections and report signs of infection immediately to my healthcare provider. The answer is C. Exercise is safe for the client with gestational diabetes and is helpful in lowering blood glucose levels. Another question is: the nurse is educating a pregnant client who has gestational diabetes. Which of the following statements should the nurse make to the client? Select all that apply. Cakes, candies, cookies, and regular soft drinks should be avoided. Gestational diabetes increases the risk that the mother will develop diabetes later in life. Gestational diabetes usually resolves after the baby is born. Insulin injections may be necessary. The baby will likely be born with diabetes, or the mother should strive to gain no more weight during this pregnancy. The answer is A, B, C, and D. If gestational diabetes is not responsive to diet and exercise, insulin injections may be necessary. Concentrated sugars should be avoided. Weight gain should continue, but not in excessive amounts. Usually, gestational diabetes disappears after the birth of the infant. However, diabetes can develop 5 to 15 years after the pregnancy. And these are the references.